This is Dr. Khan, Executive Plastic Surgery. A warm welcome to all the listeners and the viewers. A pleasure to talk to you about anything. Please feel free to ask any questions you may have, and I'll be more than happy to answer any additional questions. So I want to go ahead and get started. We had a very interesting and busy clinic today. A lot of patients came in with their complaints and concerns from what are suggestive of what is breast implant illness. One of the patients I talked to today, she had at age 20 diagnosis of rheumatoid arthritis and juvenile rheumatoid arthritis. She should not have gotten implants according to her symptoms. And this is where if someone has an underlying autoimmune disorder, there is a certain risk factor contraindication, because you do not want to complicate what are the hallmark features of what is breast implant illness, which is the joint pain, fatigue, amongst the autoimmune problems, along with what is an underlying problem such as rheumatoid arthritis. Interestingly, she had lupus as well, but she certainly was very educated, and she knew that she needed to get the implants out so that she would eliminate the chances of what would be the underlying signs, symptoms of what is the hallmark features of what is breast implant illness. So many patients will ask, what exactly does that mean? So if you look at the black box warning that was published and established by the FDA, if you see the advertisement, you will see the black box warning. You can actually go to Google and type this in. It says over here, patients receiving breast implants have reported a variety of systemic symptoms such as joint pain, muscle aches, confusion, chronic fatigue, autoimmune diseases, and others. So this is where, by definition, just from what I have read, they're telling you this autoimmune problems. There are a lot of them, right? There are confusion, which is the brain fog. The patients are like they're going to the grocery store and they're not able to figure out what exactly they went there to get. Muscle aches, joint pain. These are the hallmark rheumatological type of problems, fibromyalgia type symptoms. Then it says over here, quote, individual patient risk for developing these symptoms has not been well established. Some patients report complete resolution of symptoms when the implants are removed without replacement, close quote. And so this tells you that, you're going to have resolution. Now, how much is it, the rheumatoid or the lupus, and how much is the old implants that the patient has, and time will tell. Now, the goal and gist of the surgery, as you're aware from your research and from your networking, and I will tell you the most important thing that one has to do is to be your own advocate, listen to the many other patients, listen to their stories, listen to how the surgery was done. If you go to 10 different plastic surgeons, without a doubt, you're going to get 10 different answers. So one of my patients that came today, she is coming from Ireland. So she made the trip here for her surgery, which is scheduled for tomorrow. She did an exhaustive search, and she did a lot of back and forth, discussions with the many other patients, and she determined that this is where she has had 2 sets of implants. She has what is a partial capsulectomy after the first implant. She has a history of the rupture, and the goal here is not only to remove the entire implant capsule, which is the current set, but also to remove that free-floating silicone that was present. And not only that, but the residual partial capsulectomy. And I'll also check above the muscle to see if that first implant was possibly placed above. So there's a lot going on in her so that she gets the relief that she's looking for, especially when the implant and the capsule is below the muscle directly on top of the rib. If you go to 10 different plastic surgeons, without a doubt, you're going to get 10 different answers. And this whole surgery is about the commitment of the plastic surgeon, the determination of the plastic surgeon that that entire implant capsule must be removed in what is that preferred end block, the gold standard, or 100% total capsulectomy, such that the need for the drains are not there, that the entire capsular tissue, the capsular burden plus the implant is removed, plus any inflamed tissue, such that there is nothing bad left behind and all bad tissue, inflamed tissue is removed. And number 2, all whatever is removed is then sent to pathology to make sure it's not that rare lymphoma, that rare squamous cell cancer, breast cancer, whatever it may be, to look at the many cells like the giant cell reaction, histocytic reaction, the non-refractile material, whatever it may be, so that we have ruled out the badness. Cultures are done for bacteria and fungus. As you will see, no need for the drains, and no need for that unnecessary lift in the vast majority of the patients because of the excess skin that's removed. Now, going back to, one may choose a surgeon for many reasons, and this is one of the things that I want to talk about. Your surgeon, first of all, must be a firm believer in breast implant illness, that he or she must be talking about it actively. First of all, he has to, or she has to, recognize that breast implant illness does exist, and that I just read this off of the black box warning. So I write this down: essential surgery, non-cosmetic in nature, medical necessity surgery, desire for removal of bilateral implants, and if the patient has capsular contracture grade 3 or grade 4, I document that because that's one of the reasons that why the patient is getting her implants removed. Now, this is where the whole commitment is into removal of any and all of that inflamed tissue. And one has to always think that the implants are ruptured till proven otherwise, because you don't want to find out otherwise. If there is any fluid around the implant, that must be sent to cytology to make sure that this is not that rare lymphoma. And remember, any fluid around the implant is a big red flag for that BIA-ALCL, which is the breast implant associated anaplastic large cell lymphoma, which is indeed a true entity. It is what is relatively extremely rare. But as you will listen to the many plastic surgery societies and the FDA, this is a number that is underreported. Approximately 1,300 cases to date worldwide. Now, as you will see, majority of the plastic surgeons are not removing the capsule. And if the capsule is not being removed, it's not being sent. If it's being sent, it's not being told to be checked for CD30 analysis. And if the eyes don't see what the mind doesn't know, so you have to spell it out for your pathologist, because all what they're fixated on is the breast cancer or any abnormal pathology, breast pathology. You have to spell it out to the pathologist that they have to do a CD30 analysis and rule out lymphoma, rule out malignancy, rule out SCC, which is squamous cell cancer. So very, very important. And this is what is the second part that was highlighted by the black box warning. Quote, breast implants have been associated with the development of a cancer of the immune system called breast implant-associated anaplastic large cell lymphoma, BIALCL. This cancer occurs more commonly in patients with textured breast implants than smooth implants, although rates are not well defined. Some patients have died from BIALCL. So again, one of the other major reasons is to make sure when the capsule is sent, that in itself is physical evidence proof that the entire capsule was indeed removed, because they measure and quantify the dimensions of the capsule. And that in itself, along with the pictures that a good pathology department will take, and the surgeon certainly will take, that also authenticates that the surgery was done in the manner that it was. So let me kind of spell it out in multiple choice format. What and how do you know that your surgeon got the entire capsule? Number one, if your surgeon states that I believe in breast implant illness, well, that is a very good, healthy start. I've seen a patient that was operated on by another surgeon who did not write down breast implant illness. He said, I don't believe in breast implant illness, but I will offer you a service. And as you can imagine, that surgeon is not going to do the surgery from his or her heart in order to completely remove the capsule and do a complete, thorough, meticulous workup. The surgeon has to be actively talking about how and why he's going to do. Now, this is something in today's world and age, I can say everything that I want. Seeing is believing. And so this is very important. You may have someone who is going to have a nice sit-down discussion or a nice podcast or a nice, very good studio, very nice platform where he or she is interviewed by a very notable kind of news anchor. That does not mean anything, because anyone can schmooze, anyone can talk, anyone can wear a nice suit and show up before a camera and then talk about how and what is the essentials and what is it that his thought process is. You may have a surgeon who's a 35-year-old veteran when it comes to all the experience in the world, seen it, done it all. But if they don't believe in breast implant illness and they're not talking about it and they're not actively showing how they're doing it, that does not mean anything. So all the one patient said, well, I went to that list Remember, who's coming up with this list? These are average patients who have no concept of medicine, no concept of surgery. They are very good, what you call Facebook runners, if you will, or Instagram, social media type of people. They have excellent, I use the word networking capabilities. They know how to use the trigger words, the buzzwords, and kind of lure in and grow and basically stimulate their Facebook group. You have to be very careful because no plastic, no, the plastic surgeon cannot be assessed, cannot be graded by someone who has no concept of surgery. This is like, if you think about a bizarre thing, how do you have someone who's a Facebook group owner who has got 5,000, 10,000, 20,000, 100,000 members, and now she is now the leading authority? If you ask her to define the muscles of the chest, she will have no idea. And how is she or he coming up with then a list? So I saw this list where one of my patients said, "Oh, you're on the top 10 list of surgeons." And I said, that is a pure, bogus, artificial list, because who came up with that? Was this a trained surgeon with 20 years experience who flew from one surgeon to the next and went inside the operating room and assessed over 3 months, 6 months as to how he or she's doing it? No, this is all a made-up list. So this is what happens. Unfortunately, someone takes a name of a good prominent surgeon, another prominent surgeon, another prominent surgeon, and then they squeeze their no-name surgeon in, developed by another Facebook group or another marketing person who strategizes, and they came up with their own formula. And now they say, well, he's the king, and this person is all in that list. This is, again, there is no American Board of Explant Surgeons. There is no such thing, and no other group of surgeons who's going to basically authenticate another surgeon. There is a surgeon has a very nice office with good marble, nice building, nice area in Beverly Hills, or let's say a high rise in Sugar Land, and where they have a world of the state of the art surgery center, or someone who has been on Fox News or CBS or God knows what other channel. That does not mean anything. Ultimately, if there is one thing that you're looking for, number one, and the only thing as an explant surgeon, is to look at the high definition pictures and videos of the chest wall that shows complete removal of the entire implant capsule and all inflamed tissue. That puts to rest any question, any suspicion. Yesterday I talked to a patient. She said that her plastic surgeon removed the implant and supposedly the capsule, and then when it came time to the post-op visit, the surgeon said, "I deleted those because I did not want them on my camera." And this is where I just want to emphasize, if you ever want to tell who's the plastic surgeon entering the building, they will always have a camera. When we were in training, we were told you have to have a studio. If you have an established office, you have to take before, during, after pictures. If you were to get your gallbladder out, no one cares, no one takes those pictures, because remember, it's done and it is removed in the manner as described. When it comes to explantation, the surgeon's thought process, surgeon's meticulousness, detailedness, the transparency, the high definition pictures of the chest wall, and high definition videos with 1080 resolution of the chest wall showing complete removal of the capsule off of the rib. And in my practice, the capsule is removed along with the fascia of the intercostal muscle, the fascia of the pectoralis minor, fascia of the serratus anterior, the periosteum, perichondrium, and anything inflamed is removed, because that essentially authenticates, certifies that the capsule is definitively removed, because you do not want a puncture in that capsule. And now if there's fluid on the inside, that will leak out. If there's an implant rupture, that will leak out. And so this is extremely important. High definition pictures and videos. And I say to anyone, you should not only see that one set of pictures that are on the Facebook page or the YouTube, TikTok, or Instagram, or the surgeon's webpage, but you need to talk to at least 10 other patients who all say they got their pictures and videos. Because what I find, and having talked to some of my colleagues, whenever they do an easy case, small implant, 180 cc's above the muscle, that's like posted right on the spot and said, oh, look, I do explants and I do this end block. But guess what? The next one, that was a ruptured 600 cc implant that was super glued, that was done in a very unorganized way. The capsule is cauterized and burned, but not physically removed. That will not be posted. So you want to make sure that from one patient to the next, the surgeon is giving all the high definition pictures and videos. And if your surgeon is not using drains, that certifies, in my mind, or authenticates that your surgeon did the right surgery. The last time I used drains was almost 5.5 years ago. Your surgeon must clearly state that he or she is removing the whole capsule. Anyone can remove implants. But remember, this whole surgery is about the finesse and etiquette, that if you have a ruptured implant, that it is removed in the manner that is openly described by the surgeon. And this is where you have to go to the YouTube shorts, like in my case, and you will see all what I have done posted. You direct message any of my patients, you will see the high definition pictures and videos of the chest wall showing complete removal of the capsule. So there is no second guessing the process. And remember, this whole surgery is about the capsule plus the implant plus all of that inflamed tissue. And majority of the times when it is below the muscle, the entire capsular tissue is removed faithfully, sincerely, with honesty, with integrity, because that is what ensures that you're going to have the best bounce back from your many symptoms of what is suggestive and consistent with what is breast implant illness. So let's say if your surgery is done tonight, you know with confidence that the entirety of the implant capsule was removed, number one, and number two, the entirety of that capsular tissue was sent to pathology. I see some surgeons sending a small piece. Why not send the whole thing? Now, one of my other colleague friends has said, this is where, this is the ultimate proof, where if you're removing the capsule, sending it off, you yourself next day can go to the pathology department and say, well, I want to see my capsule. And this is where it will be proof, because the pathologist also measures in dimension how many centimeters width and length, and how circular, how nice, how grossly defining the capsule. So not only the pictures, but also the high definition pictures of not only the chest wall, but certainly the high definition videos and pictures of the chest wall, but also cutting open of the capsule on the table. So cutting open of the implant capsule on the table is still not enough. You have to show the high definition pictures and videos of the chest wall showing complete removal of the capsule, because that is the ultimate of proofs. There are many surgeons who write in their op note, I removed the whole capsule. Lo and behold, I go in, like the last case that I did, and lo and behold, the patient had what was entirety of the capsule left behind, even though the patient was told they removed all the capsule but on the chest wall, and the entirety of the capsule was left behind. Now, what are the 5 ways that you can tell that the surgeon did the right surgery? That means got the whole capsule out. Number 1, the surgeon is a firm believer and not augmenting, and talks about it with transparency, and gives basically a lot of lectures and talks that in itself speaks volumes. Now, believe it or not, this is still not the test. The second thing is 4 hours plus minus to just remove the implant and capsule. So I see some surgeons who meet criteria number 1 somehow, but number 2, when you see that they're done with a supposed lift, a supposed explant, and supposed fat grafting in 2.5 hours, I will tell you that is literally virtually impossible, because that fat grafting is an absolute no-no in my books. It is, remember, if 100 cc's of fat is injected, 50 to 70% of the fat will get absorbed, would not take. And some surgeons even mention as far as 80% is not. So I use the word 50 to 70. Now remember, it's not only dependent on the surgeon technique, but the patient's fat that was harvested, the quality of the fat. You cannot say I have a 70, 80% take of the fat. This is virtually impossible to hear. And if you do your research, you will see there are a lot of risks. There are small, 5-10% of the time you can get a nodular fat tissue, and that might be palpated and might throw you off and say, is this breast cancer fat necrosis? Is this nodular fat that did not take because it didn't get this optimal blood supply? Oil cysts can form. Sometimes it deposits well on one side, and on the medial side it does not, and you can get an indentation. Fat grafting then has to be repeated maybe 2, 3, 4 times just to add that volume. And remember, even when they add it, they do like 100, 150 cc, so it's not much of fat that's injected. Fat necrosis can occur, infection can occur. You can have acute and chronic pain, sometimes problems at the donor site. So the first thing, again, is the surgeon must be not augmenting, only explanting, and talking heavily about how he and she does it. Number two, the length of time should be plus minus 4 hours. Number three, the length of the incision should be the diameter of the implant plus minus. So I see another surgeon did like 3 centimeter incision for what is a 600 cc implant. You can imagine, and with absolute certainty, that this did not occur where an entire capsule was removed in the manner, because no surgeon will be able to dissect in 3 centimeter space where they have to dissect all the way up. Number four, you have to have that high definition pictures and videos. By far, this is the most important test, because the pictures cannot lie, the videos cannot lie, not only of the chest wall, but also on the table. So the both you combine and you will see. And number five, you will see the patients on social media, where you have a platform like Facebook, and now the patients are heavily talking about the surgeon, authenticating it, certifying, and saying that they are content with how the surgery was done. Now, another thing I want to, so this is again very important. This is like the check and balance, if you will, not only on all the other surgeons, but myself too, because this is very important. And this is what I make a point. My surgeries are more about precision, accuracy, determination, honesty, integrity, where there's complete transparency from the time you talk to me. I am the limiting step in this whole process, because I'm very much hands-on from the time I talk to my patients to the day I do the surgeries to the post-op follow-up as well. I do not delegate this to any of my PAs, nurse practitioners, or nurses, or the medical assistant or the office manager, because they have no concept of the surgery. They do not know what happened in the OR, and that is risky business in order to pass on this burden of having the nurses and non-surgery allied health people talking to the patients post-op. The fact that your surgeon does not put in implants authenticates that there was no tissue left behind that was bad. Our entire capsule was removed. There was no spillage of the silicone, and that there was no indication for putting in the drains. Now, the other thing I just want to mention is this was a very interesting clinic. I saw another patient of mine that I talked to, done a phone consult. She just got her implants from Korea just 3.5 months ago, and she already started checking off boxes, and her body's reacting fast. Another patient I saw today, she had implants done 21 years ago, and she said she was fine till a couple of years ago, and then all of her symptoms kind of went haywire. And she said, what is and how is this my body reacting? And this goes back to showing in the black box warning, breast implants are not considered lifetime devices. The longer people have them, the greater the chances are that they will develop complications, some of which will require more surgery. So if a surgeon tells their patient that you're going to die with them and that you're going to be quote unquote buried with them, that is wrong information. This is clearly defined to be wrong. Anecdotally, 10 years plus minus before the problem arises, 7 to 10 years in my books. For this patient, it was 3.5 months. 3 months later, she knew that this was something that did not sit well with her body. These are, remember, foreign devices. The body is reactive. And, you know, if I may use this again, not my words, anything that I'm saying today is not my opinion. These are words that I'm reading directly, and I'm just translating in clinical practice. So here's another documentation. This is, you can certainly Google this, breast implants, certain labeling recommendations to improve patient communication, FDA issued September 29, 2020. And as you will see on page number 9, you have the black box warning right here. And as you will see, then they talk about the patient initials. So these are the risks that have been discussed. So risk of breast implant surgery. Remember, this is something that should not come to you as a surprise. because your surgeon has already talked to you. I understand that the risks of undergoing breast implant surgery. I understand the risks of undergoing breast implant surgery may include breast pain, skin or nipple areola sensitivity changes or loss, asymmetry, impact of aging or weight change on the size and shape of the breast, infection requiring possible removal of the implant, swelling, scarring, fluid collections, hematoma, tissue death of breast, skin, or nipple, inability to breastfeed, complications of anesthesia, bleeding, chronic pain, damage to surrounding tissue such as muscle, nerves, blood vessels. And then they talk about impact on imaging of breast tissue. And then they say they want your initials. Then they talk about the lymphoma. The other thing I want to talk about on page 14, remember, not my words, you will see, I understand, quote, I understand that silicone can migrate from my implant into nearby tissues, chest wall, lymph nodes, under the arm, and organs, liver, lungs, where it may not be possible to remove. I understand that all breast implants can interfere with mammography and breast exams, which could delay the diagnosis of breast cancer. Mammography can also cause the breast implants to rupture or leak. I should tell the mammography technician if I have breast implants. And then it says over here, I understand that long-term risks of breast implants may include painful or tightening of scar tissue, which is capsular contracture around my implant, rupture or leaking of the breast implant, wrinkling of the implant, visibility of the implant, shifting of the implant, need for reoperation. I understand that all breast implants contain chemicals and heavy metals. I understand that most of these chemicals stay inside the shell of the implant, but small quantities have been found to diffuse gel bleed through the implant shell of silicone gel-filled implants, even if the implant is intact and not ruptured or leaking. A list of components, chemicals, and heavy metals is available in the patient information booklet. And then they want you to do initials. That means your surgeon has discussed this with you. Now, if you look at this page right here at the bottom, heavy metals found in breast implants: arsenic, beryllium, cadmium, chromium, cobalt, copper, lead, magnesium, mercury, molybdenum, nickel, platinum, selenium, silver, tin, titanium, vanadium, and zinc. So just from what I've read, this should not come as a surprise. And we just want to, in a very professional, nice, remind you now, for majority of the patients, well over 95, if not 99% of the patients, this is news to them, whatever I just read. And remember, this is where the surgeon must have. So as you look at this, what does it say at the end? Confirmation of discussion of risks. I acknowledge that I have received and read the patient information booklet brochure for the specific implant that will be used during my surgery, and that I have had time to discuss the information in it and on this document with my physician. I have had the opportunity to ask questions and understand the benefits and risk of breast implants for me, given my specific health conditions. I have considered alternatives to breast implants, including reconstruction without breast implants, no reconstruction, augmentation, and their benefits and risks. And then the surgeon writes, physician signature, not the office manager, not the nurse practitioner, not the PA, not the medical assistant, not the medical student. Physician signature. I acknowledge that I have discussed the benefits and risks of breast implants as described elsewhere in the patient information booklet brochure and in this checklist. I have also explained the benefits and risks of the alternatives. I have encouraged the patient to ask questions, and I have addressed all questions. Now, this is essentially part of that informed consent. There's a very nice podcast / interview that I did with Christian Elliott. I want you to please go ahead and listen to it. It's a couple of hours, but you'll get a lot of information. I want ultimately you to listen to what the FDA is saying, to what the manufacturers are saying, to what ultimately the patients are saying. Because remember, this is where the patients are making their own decision, and they're making their own critical thinking, and they're putting the two and two together, and they say they don't want no more. Because today, for example, I saw the 61-year-old nice lady. Does she want to deal with this 10 years later, plus minus 71? In 2 weeks, I will be doing a Facebook Live with one of my very nice patients. She is just turned 90. I already did a Facebook Live with her a few months ago, and she wants to continue to speak her mind, and we will see how she is doing, and we will hear from her and her daughter. who has been instrumental in making sure that mom is doing very well. So we'll hear from another 81-year-old patient who had breast cancer, who in 4 years had what was a ruptured implant. So she got it in 2021, my own patient. And 4 years later, 2025, when I did her surgery, this is the November 10th Facebook Live, you will hear directly from the patient herself. Remember, this is a movement by the ladies for the ladies. And remember, if you are hurting, capsular contracture, grade 4, or if you have malposition or any issues like fluid or ruptured implants, there is a sense of urgency into removing them so that it is all contained badness. None of this spills into the chest. If your surgery is done today, you have that peace of mind and that confidence that your surgeon, number one, got it all out and did the complete workup. What is the Kahn procedure? I want you to please go ahead and look into the Kahn procedure. Number one, no unnecessary lifts, no unnecessary drains. The last time I used drains was well over 5.5 years ago. High definition pictures and videos of the chest wall and also on the table showing cutting open with sterile gloves. Number 4, implants are returned to the patient, be it saline or silicone. Number 5, the capsules are always sent to pathology and quantified, measured, such that CD30 analysis is done. Number 6, the microbiology specimens for aerobic, anaerobic, and fungal cultures. Number 7, no twilight deep sedation. This is how I do my surgery. My very last patient that I saw today, her husband is an anesthesiologist, and she basically, when I discussed with her, he was all 100%, and you will see it's very safe. If I'm a number 8, that no matter what the age, be it the 89-year-old patient I operated on, the 81, or the young 22-year-old, from all walks of life with underlying medical problems, patients who have been on prednisone for 40 years, they all get the same surgery. So if I talk to some of my colleagues who are doing explants, they say, well, this was easy, so I did it the right way. Another colleague of mine that I was doing a Zoom call with, he mentioned, well, when the going gets tough, I back off because I don't want to give a patient the pneumothorax, and I cauterize the capsule and I say that's good enough. That's an absolute no-no. That you do not want to leave that burden behind, and now the patient might be improving 70%, 60%, and we know the whole subset of patients who have already gotten an explant and their capsules were not completely removed, and then post-op, they behaved as if they still had implants or there was partial improvement, and now they're seeking out surgeons who are doing residual capsules. You do not want to be that patient. And this is what I've said in the past. This is my worst patient case scenario, where there an attempt was made, even though sincere, and the surgeon's quote ego was tested, and he said, of course I can do whatever you want me to, don't underestimate my power. And the next thing you know, when the going got tough in the OR and the capsule was super thin or tightly adhering to the chest, now the patient was given disservice, and the patient had residual capsules. The capsules were left behind. And we see this from time to time, where the surgeons are dictating and writing notes that the end block was done, and you see the pictures, and I will say this was far from an end block, or the patient's complaints still linger on. And when I go in for the exploration surgery on the chest, you see what are clearly residual capsules left behind. Remember, this is a relatively invasive surgery, involves surgery, 4-hour surgery just to remove the implant capsule, and it requires a very dedicated, sincere mind. So there's 2 conditions to it. Number 1, the surgeon has to, in her or his mind, be absolutely sold on the idea that the patient's post-op course is dependent on removal of the entire capsule, implant, and all inflamed tissue. And number 2, the condition that the surgeon must be able to carry out the surgery consistently from one patient to the next. And so this is where the surgeon should and must have a track record of having done the surgeries. And this is where you go to YouTube Shorts, and you will see all these high definition videos and pictures, in my cases, where the surgeon is gladly sharing this with AirDrop, all the high definition pictures of not only the chest wall and videos of the chest wall, but also the cutting open of the capsule and implant on the table, and also discussing very definitively that it was done in the manner as described, and that you and the surgeon are on the same page and not second guessing. This is what I've said in the past. Go to your surgeon and say you just want the implants removed, and see if he or she says if the capsule removal is important or key. And if he is not pressed on the idea, oh well, I'll see how bad it is, your surgery will be compromised. In my practice, I always see, and this is what I said on one of the other Zoom meetings with my other colleagues, I don't give a second chance. I want, ultimately, when the surgery is done, complete, definitive, honest, sincere, complete removal. And number two, high definition pictures, videos to authenticate and certify. And number three, all what is done is very transparently laid out to the patient so that there is no second guessing the process. And this is what you from your heart and your mind and soul should be content. I saw another patient and said, well, I don't have the money. I'm going to have my insurance covered. If I don't get better, I'll come to you. I'll tell you that surgery with the redo might be more challenging. What if it's a ruptured implant, to the patient's surprise, and now it spreads to the neighboring area? One of my other patients mentioned very smartly, if the silicone spills into the chest, one other patient said, well, you can irrigate and wash it out with 2 liters of copious normal saline or antibiotic irrigation. I'll tell you, once the silicone spills in the chest and you wash, irrigate it, you're going to spread this badness around more. And now it's going to be more diffuse, just like slime would spread all over the table if a kid is playing with it. Same thing. You don't want that to spread all over. And we have all seen the so-called safer, better gummy bear implants. They melt just like the older ones did. The new ones, when they're fresh out of the pocket, you can drive a car over them. You can indeed very much cut them. But when they're incubating in the chest, you have seen the way the implant literally disintegrates, melts, and it's liquid, viscous, thick, sometimes fluid forms around it. You don't want any of that to spill into the chest. So there's a certain etiquette, there is a certain thought process, there is a certain sophistication. 3 of my patients had CD30 positive within the last year and a half. They did not have to come back to redo or remove the capsule because they got the right surgery. 10 of my patients over the last 3 years or so have been fungal positive. They got all the implant capsule, all bad tissue removed, so there was no going back and removing it. 3 of my patients that I've done over the last couple of years have had breast cancer come back within their mastectomy flaps, and they got the surgery already because all the badness was removed and there was nothing more to be done because the entire right and left mastectomy scar was removed, the capsular tissue was removed, anything around the implant was removed, and so there was no, quote, burden left behind. And this is where it's all about the peace of mind and tranquility. Now, I want to go ahead and end up with this discussion. One of my patients reached out to me on Saturday and she said, well, look at my chest. It's how deep contracted it is. And I told her, you have radiation to the chest. You have grade 4 capsular contracture to the chest. You had a cluster of metal clips that were left behind. And I removed that tissue and the left upper axillary mass. And all of that scar tissue was removed. And this is where, thank God, you did not get an infection, skin necrosis. And remember, whenever you have radiation of the chest, it burns the skin and the nerve endings are shot, the blood vessels are shot, and the risk for potential infection complications goes up. And so and she was just literally 2.5 months or so out from her surgery, and she has a long ways to go. This is something that will occur. Now, I want to mention one thing as well. Guess what over here? Page 10 of that same, I understand that if I have any of the following conditions, I may be at a higher risk for a poor surgical outcome. Medical condition that affects my body's ability to heal. Diabetes. Definitely poor wound healing. Connective tissue disorder. So I saw a patient today, she had scleroderma. And we're going to hear from her in the next few weeks. She's going to be a Facebook Live. So that sets you up for a poor surgical outcome. Active smoker or former smoker, definitely smoking horrible for any plastic surgery, any surgical procedure. Currently taking drugs that weaken the body's natural resistance to disease, such as steroids or chemotherapy. Prednisone, steroids slows down the wound healing. Tacrolimus, which is a transplant medication. My neighbor, she had what was a kidney transplant, and she ended up getting breast cancer. And her surgeon put an implant in her. If you ask me, she was absolutely not a candidate. And I told her not to get the implants. As a good neighbor, she did not ask me, but I was proactive in telling her, and lo and behold, she did get implants. According to this, she was set up for problems, infection, whatnot else. Um, uh, um, all these chemotherapy agents as well. Remember, the chemotherapy agents decrease the white count, and now you may be more prone to infection, for example, depending on the side effect of the medication. History of chemotherapy or planned chemotherapy, history of radiation therapy. Um, a patient had cystic fibrosis, for God's sake, and the board certified plastic surgeon put in implants in her. Remember, she set up for lung infections, and there was absolutely no need for that. And so that was a contraindication for putting in implants, because remember, she's going to cough, the chest tightness, capsular contracture, and the young lady absolutely did take her implants out, and she was certainly very much relieved. Certain conditions that interfered with wound healing or blood clotting, like hemophilia, factor V Leiden deficiency, protein C deficiency, antithrombin 3 deficiency, reduced blood supply to the breast tissue. Some patients have had 2, 3, 4, 5, 6, 7, 8, 9, 10 surgeries, believe it or not, and that's compromised breast tissue. I understand the following conditions have not been adequately studied to determine what the conditions put me at higher risk: autoimmune disease, Hashimoto's, lupus, rheumatoid, clinical diagnosis of depression or other mental health disorders, including body dysmorphic disorder or eating disorder, or have other products permanently implanted in the breast. Patient initials. Now, I just want to go ahead and read something at the bottom over here. It says breast augmentation options. I understand at the bottom of page 15, I understand, thank you, Mark. I understand that breast augmentation may result in permanent changes to my breast tissue, and if my implants are ever removed, I may be left with unsatisfactory appearance, changes to the size and shape of my breast, including but not limited to dimplings, chest wall concavity, puckering, sagging, or different incision size or location. If I am an augmentation patient, any additional surgeries or medical procedures will likely be at my own expense. And so this is a big deal, especially the cosmetic patients. So one of my patients told me that I went to this other surgeon's website, and she has like the best top 10 pictures. I said, I have almost 1 million pictures. I can go ahead and put the top 200, and I can easily find top 1,000. I'm not going to trick, deceive, motivate, and be cunning enough to misguide you and say, well, you're going to be my patient number 11. I could easily do that. When I made my website company said, we can give you these model pictures, and there are these bank of pictures that are exemplary, and this is what you can post, and at the bottom you can write model pictures. And I say, I dare not do that. You have to know, if someone has a ruptured implant, 800 radiation is very different compared to the 800 normal with no radiation and non-rupture. If someone is a poor wound healer with scleroderma, and remember, we know this. So someone who's posting all the 10 pictures, that in itself is, if you ask me, deceit, and it's not honest, and there is an ethical implication into persuading someone and saying, hey, you come here, you're going to be that picture number 11. One of my patients even told me, these are all coming from my patients, and I talked to all my patients. She said she saw on one patient's website in Dallas that this surgeon posted a picture of a patient, and then in California, another patient had the exact, this surgeon had an exact picture of the same patient. And this is where they're using this from the bank and showing pictures as to what model results that they have. And again, if you ask me, that is unprofessional, wrong, and it is misguiding. And this is where I tell, and this is going back to the point, go to Facebook and have all your patients discuss what the results are with one patient to the next, so that you're actively letting the patients kind of figure it out and seeing how he or she is doing it. Not like, oh, now the other thing I want to mention here is, please go to YouTube and type in mastopexy with explant, the cut around the nipple up and down. And I want you to see, this is your homework. see for yourself what it means to cut around the nipple up and down, so that you know, again, this is part of the informed consent. So you can see the invasiveness of that surgery, i.e., that elective, most of the times what I call unnecessary lift. And so I want you to go ahead and see that. And so again, this is all the research, networking, homework, analysis, and you can tell a lot about a surgeon. You want to be not talking to the liaison, who's a very good person on the phone and kind of someone whose job is to get paid and recruit patients to the surgeon's practice. I have had another surgeon who actively sought my patient who was driving here and telling her that anesthesia is dangerous. And this is where she's giving active medical advice, and she's not even a nurse, and not even in the medical field. And she is actively coaching my patients as to what is better anesthesia. And here you have an anesthesiologist who came with his wife at the last patient for the day, and who said twilight D sedation is an excellent choice, and this is what he would recommend for all of the surgeons. So the point I'm trying to make here is, don't listen to the many other forces other than the surgeon, so that you get the definitive answers. We live in a world where there's a lot of trick and deceit, so you want to be doing your homework. When you come to me, there are patients that I've talked to, and when I discuss and they feel uncomfortable, the most important thing is they've gotten the message directly from me. And there was a patient from Canada, just to use this as an example. She reached out to me and she said she has sensitivity to this medication, possibly, very likely, this medication. I said to her, please go ahead and go to your doctor and have your doctor, be it an allergy immunologist or primary, document that this is the medication. She said, well, I know my body the best, and I know I had sensitivity to this, and I had some blisters on my scalp from this medication. I said, how do you know that? She said, I just know. I said, well, first thing is first, I have to see the allergy immunologist, that they do all the tests, and I don't want to do and give you something that may end up hurting you. Then I made a determination that no matter what, because you have a lot of sensitivities, I have to do you at the hospital for her own goodness. Remember, I would love to do the surgery at my surgery center. As I said, I don't want to do something that there is a lot of unknown. And she was reluctant to. And then I very nicely, humbly said to her, I'm sorry, I don't think I'm going to be the right surgeon for you. And you should seek another surgeon out, so that if your surgery and when your surgery is done, there needs to be a lot of checks and balances. The anesthesiologist needs to be aware, like at the hospital, and it has to be done at the hospital. So God forbid that you have a reaction, whatever it may be it a breathing reaction or asthma reaction or a scalp rash or whatever it may be during surgery, that they have the tools and techniques and full access to this to the hospital. And this is where she was not happy with that answer. And certainly, remember, it's my choice as well. There was another patient from the Midwest. She had radiation to her chest, and she was on and off prednisone. I told her, you're relatively high risk. Just the fact someone has radiation, from my experience and my taking care of patients from 1998, patients who have had radiation, the risks for implants and radiation, 30 to 50% problems for complications like infection, wound dehiscence, capsular contracture, asymmetry, skin necrosis, altered sensation, malpositioning, amongst the many other problems that the radiation can cause. So do your homework, do your research, talk to the surgeon, talk to the surgeon's patients who he has operated on, because that is going to validate the surgeon. Do not listen to any Facebook group owner. Do not listen to another liaison who's paid and incentivized and gets kickbacks. If you ask me, this is a marketing person directly working. It's not an advocate. It's an advocate for the surgeon. So do your homework, do your due diligence, network, talk. Take another person with you. Two minds are better than one. And be content from your mind, be content from your heart, and give it some time. Do not rush into this, what is a big decision-making process. And if you're ever not sure, the smartest thing is to wait, but get your homework, do your homework, get your homework done, do your homework, and feel content from your heart, from your mind, that as you sign up for the surgery, you are actually happy and looking forward to a better quality of life as 90% of my patients will attest to the fact that they have had many relief of their symptoms or what is suggestive of breast implant, be it capsular contracture, acute and chronic pain, or whatever it may be. So there you have it. This is Dr. Khan. Please share, please discuss, and I look forward to talking to you again very soon. This is Dr. Khan, Executive Plastic Surgery.